Hello, everyone, and welcome. I am Autumn Lintz, the Education Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A. We are very excited to have you here. Before I introduce our wonderful panelists, I'd like to go over some housekeeping. Q&A. This is why we are here. Please add your questions to the Q&A tool. We will be recording this, and the video will be available on the Foundation's YouTube channel in a few days. We will also send a link via email to all who registered. We would like to thank our individual donors and our funding partners for making programs like this possible. We cannot do it without you. This is how we exist, and this is how we are able to produce patient education forums, webinars, publications, and other educational materials. So thank you for your donation. Upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. We do use the feedback to guide future programs and to ensure that we are meeting the needs of the community, so please take the time to complete the survey. Now, I would like to share some information on our speakers for today. First, we have Dr. Brad Haverkos, who specializes in hematology and oncology. He is an associate professor, medicine hematology, University of Colorado. His research focuses on developing novel management and treatment strategies in aggressive lymphoma subtypes with a focus on mature T and NK cell lymphoproliferative disorders, including T-cell lymphomas. Dr. Haverkos has numerous peer-reviewed publications. We also have Dr. Theresa Pacheco. Her specialty is dermatology. She's an associate professor, Dermatology, University of Colorado. She has over 29 years of experience in the medical field. She has extensive experience in skin cancer and excision, and cosmetic skin procedures. She graduated from the University of Rochester School of Medicine and Dentistry. Thank you both for joining us today, and let's go ahead and get started. Welcome, Dr. Haverkos and Dr. Pacheco.
Thanks, Autumn.
So we have our first question up here. Can CTCL go into remission?
I guess I can start off and answer that question. So certainly CTCL can go into remission. We have lots of potential therapies which we can elaborate on, and both skin-directed therapies that Dr. Pacheco can elaborate on that are obviously focused on the skin and direct to the skin, and then other systemic therapies, and any number of these therapies can lead to a remission. And remission can be defined as complete remission, where all of the skin lesions go away, or partial remission. And one of our goals is usually to get someone into a complete remission, and certainly that's possible with the number of different therapies that we can offer. I don't know if
Dr. Pacheco, would you like to add to that?
Yeah, I can talk about kind of the skin-directed therapy in early stage disease. So we stage disease, based on the amount of skin involvement. And I think it's fair to say that if you have early stage disease with limited skin involvement, it's fairly easy to get patients into remission. And again, we have skin-directed therapies like phototherapy, topical medications, localized radiation. So there are lots of treatments for early stage disease, and it's very likely that patients can go into remission with early stage.
Great. Thank you both for sharing that information. Is there any history of excessive sweating related to MF?
So I can speak to that. So excessive sweating, the medical term for that is hyperhidrosis. And I'm actually going to say no, that we often do not see. It's not common for us to see excessive sweating in patients with mycosis fungoides. I'm just going to say no, because I haven't seen that as a common complaint.
All right, thank you. Our next question is, what are the best ways to care for skin?
So that's a great question. And, because mycosis fungoides often presents and looks like dermatitis, it's very important to, use very safe, gentle products on the skin. So I think for soaps, we like soap products. So what that means is liquid soaps that are not stripping to the skin. Our favorites are just Dove and Oil of Olay or Cetaphil. Those are liquid soaps. Sometimes you don't even need to use a soap or a non-soap product on the skin. You can just focus on, kind of washing the genital areas under the arms and just clean the skin with water. As far as, skincare, again, we like bland moisturizers. Again, we have some favorite brands like CeraVe, Eucerin, Vanicream. They're often inexpensive and very easy to find. And we like those products because they have few ingredients that are that could potentially cause irritation to patients with mycosis fungoides. So when you have active lesions, your skin is compromised. So the barrier of the skin is not intact. And what that means is that ingredients in different skincare products can penetrate into the skin and cause irritation. Hence, mild soaps and bland moisturizers.
That's really good information on treatments on that. Thank you. What are the initial signs and symptoms of progression of MF?
Yeah, so I'll jump in since Dr. Pacheco has been doing a lot of talking. Usually we see that people will present with a pruritic rash that sometimes can mimic eczema or dermatitis, and many people have a several year history of a pruritic or itchy rash before they get a diagnosis. And so, there are different sort of phenotypes or flavors of how this presents, but usually the rash will present as an itchy rash on what we call a sunbathing suit distribution. So non-sun exposed skin areas is where the rash usually presents. And so usually we'll see people like Dr. Pacheco was saying, early stage disease where there's skin only involvement. We do always assess for all the different compartments that can be involved in cutaneous T-cell lymphoma, which are the skin, lymph nodes, blood involvement, and organ or visceral involvement. So we always want to check these places, but the vast majority of patients present with skin-only disease. So most of the time we can get people into a remission, like Dr. Pacheco was saying, with just skin-directed therapies, classically phototherapy. But when people progress, usually it manifests in the same way that it had initially, with a progression of their pruritic rash that we either call patches or plaques. There are some scenarios where individuals, in addition to skin progression, can progress in other places, but that is the minority. The vast majority of people present just with skin-only involvement and progress with skin-only involvement. And usually when people progress on things like phototherapy, for example, or light therapy with skin-only involvement, that might be a scenario where we think about adding some other drug that would help to get them back into a remission or get their disease back under control.
Okay, thank you. And that is actually a perfect segue into the next question. I am going through phototherapy and notice the lesions seem to be lighter some days, darker than others. Is this normal? What should I expect?
So I'm going to say, yes, that's normal. So I like to tell patients who start phototherapy that their lesions will change during successful therapy. So I often say lesions will get worse with therapy because the light is kind of bringing out the disease that we can see and the disease that we can't see. And so often lesions will become more pink or red in response to the phototherapy. The darkness that you're describing, usually that's when the phototherapy is successful and the lesions are going away and the inflammation has left kind of what we call post-inflammatory hyperpigmentation. That means that the melanocytes have been kind of activated during therapy and by the disease itself, and leaves behind some melanin, kind of a stain to the skin. So often lesions become darker. And then as far as lesions becoming lighter, I'm not sure exactly what that means, but we do want the lesions to lighten out. So go from a pink and red to a normal skin color, or a darker hyperpigmented lesion to eventually a normal skin color.
Yeah, maybe I'll just add, Dr. Pacheco always likes to say when we see patients together that it's really important to sort of understand an individual's skin, because I think everybody's a little bit different in terms of how their skin, of course, looks and their pigmentation in their skin. And really, there are different types of mycosis fungoides, and that can look different in the skin. For an example, some people have what we call hypopigmented mycosis fungoides, where they lose the pigment, and that's very different than other individuals where it presents as classically sort of a red, itchy rash. And sometimes the rash is flat, where you can't feel it, and sometimes it's a bit thicker or rough. And there are still other subtypes where the skin can even kind of look sort of wrinkly, or there are just different kinds that Dr. Pacheco, being a dermatologist, certainly appreciates much better than myself. And that's why it's really nice to sort of, for us both to see patients and to have sort of the expertise of both dermatologist and an oncologist that can help treat you and make sure that we're identifying, how you're ensuring that you're responding well to the therapy. And if there is a progression or the skin's getting worse, we really want to make sure that it's a progression and not just, like Dr. Pacheco was saying, that where the skin may be changing colors or changing the way it looks because of the light therapy, when really it's responding.
Yeah, it's a very good point on making sure that you're seeing the different doctors to ensure that make sure that you're getting the best care, and having both doctors meet with you is always important. All right, our next question: what topical creams, moisturizers do you recommend for helping keep skin from getting dry and flaky? And I know Dr. Pacheco kind of touched on this a little bit, and I think this is another one for her.
Yeah.
So I'll reiterate. So we like bland moisturizers. Our favorite brands are CeraVe, Eucerin, and Vanicream. But I'm going to go ahead and add something out of the box right there. So one thing that does work well for any dry, itchy skin is cold pressed oils, in particular grapeseed cold pressed oil or safflower cold pressed oil. They very much mimic the lipid content of the skin and can be great cheap moisturizers. So I would add that as kind of a little secret to just moisturizing dry, compromised skin, especially in patients with cutaneous T-cell lymphoma, mycosis fungoides.
Yeah, I always like to say that Dr. Pacheco is sort of the master of lotions and potions. And I was just going to ask Dr. Pacheco a question if she has any comments or elaboration on the use of topical steroids and different potency of them, and when we use them and how they may be helpful.
Yeah, so topical steroids are first-line therapy, if you read in the textbooks, for a mycosis fungoides. So I think most of you all out here on this webinar have been given a topical steroid because we use them often in the treatment of inflammatory skin disorders in dermatology. What I will say is the high potency topical steroids. So there's seven groups of steroids, and group 1 is the strongest and group 7 is the weakest. We tend to favor the high potency topical steroids like group 1, 2, and 3. And there's different names, and they come in creams or they come in ointments, but they can be used for active lesions and then active lesions that itch. Kind of what Dr. Haverkos spoke to early. So when people present with this disease, they have a red patch or plaque, and often their skin is pruritic, itchy. And so the topical steroids work to help reduce inflammation and the itch. I will say, in full transparency, topical steroids treat the symptoms, but not the disease. So if you stop the topical steroids, the lesion will come back, and it does require another skin-directed therapy or systemic therapy or all the tools that we have in the toolbox to treat this disease.
Mm-hmm.
That was some great additional information. Thank you. Next one, they are talking about specific treatment. I was put on Accutane. Is Accutane a temporary treatment or an ongoing treatment? And do the rashes ever go away or just fade?
So I'll defer to Brad on the treatment of Accutane and whether it's an ongoing or short-term therapy. And then after he's done, I can talk about the rash that comes with Accutane.
Yeah, I mean, it's a great question, I think, and we get asked a lot, when, for example, when phototherapy, which is usually our first go-to therapy for individuals, if the phototherapy doesn't get someone into a remission or it comes back at some point, we may want to add a therapy. And one of our typical therapies that we like to add are retinoids, and Accutane being a retinoid. The other retinoids that are used, and probably one that's used more commonly, is tartretin or bexarotene. And these are some of our oldest drugs that we use in CTCL or mycosis fungoides, and can be very effective for some individuals. And there are some potential side effects of the drugs that we watch out for, but they're usually things that you don't necessarily feel, more so that they're side effects that we watch for in the lab abnormalities. Like your thyroid, it shuts down your thyroid, so we usually monitor your thyroid levels and alters your cholesterol levels. So we usually check those things. And the way that we like to approach it in our clinic is we like to get someone into a remission with any given therapy, whether that be light therapy or Accutane, for example. And then once we get into a remission, that may take 6 months, year, it maybe take longer for some individuals. Once we get into a remission, then we discuss the pros and cons of staying on the drug or skin-directed therapy versus tapering it or coming off of it and watching you. So it's very much individualized, and it's a lot based on, what are the side effects of the drug? Is the drug causing any side effects? What are the risks of stopping it? Namely, that the disease would come back. And so, these therapies like tartretin and Accutane are not typically thought of as really curative therapies, but they can put people in remission and get a good response for many years. So I think we like to individualize the therapy, but really once you start a systemic therapy, there isn't a specific end date in mind. It's just get into remission or get as best a response as we can, and then discuss the pros and cons of stopping or tapering the dose.
Okay, and then I'll jump on to the second part of the question, which is the dry skin, which is a side effect from the Accutane, or also known as isotretinoin. So we use that drug commonly to treat nodular cystic acne in teenagers and young adults. What we know about the side effects is they're dose related. So the higher dose that you're on, the more side effects you have. So doses range from 10 milligrams up to about 80 milligrams per day or even higher. So patients on a high dose of 80 milligrams a day are going to experience more dry, flaky skin than someone on 20 milligrams a day. So I think that's how I would answer that question.
Okay, thank you so much. So someone is asking for a clarification when you gave the 1 through 7. What group of topical is, and I'm not even sure how to say this, so if one of you can finish the pronunciation for me, I'd appreciate it.
So triamcinolone and clobetasol. Clobetasol is a group 1 steroid, and triamcinolone is usually a group 3. There's different concentrations of triamcinolone, and some come in ointments and creams, but for the most part, they're group 3. So they're both pretty potent topical steroids, but clobetasol being the most potent.
Thank you. We're going to move on to our next question. Is lymphomatoid papulosis considered a diagnosis in cutaneous T-cell lymphoma?
I'll defer to Brad on that.
Yeah. So there's certain organizations that give classifications to different kinds of lymphomas or lymphoproliferative disorders. So within cutaneous T-cell lymphoma, we have the most common subtype of mycosis fungoides, but there are other types of cutaneous T-cell lymphoma, mainly Sézary syndrome, which is sort of some would just call it a subtype of mycosis fungoides, and then primary cutaneous anaplastic large cell lymphoma. But there are other things that get kind of lumped in and called cutaneous T-cell lymphoma, like lymphomatoid papulosis. But really, this is not a cancer. It's a lymphoproliferation. So meaning that the lymphocytes are proliferating in the skin. But according to some of our pathology colleagues, it doesn't really meet the criteria for cancer or lymphoma. So it really shouldn't be called technically a lymphoma. It should be called a lymphoproliferative disorder.
Okay, thank you. And on to our next question. The always asked but hard to answer, is there a cure coming?
So I'm also going to defer to Brad on this one. I think there's some interesting things coming.
Yeah, it's always challenging to come up with a end-all cure-all for this type of disease. We do have. So the short answer is, for most individuals, there's no cure. There are some cures with things like bone marrow transplant or donor bone marrow transplant, but it's not an option for everybody, and it carries a lot of risk with it. That would be the only potentially curative option for cutaneous T-cell lymphoma as of 2022. But there are lots of exciting drugs coming down the pike, and who knows what the future holds. There may be cures, but the one thing we can say right now is that there are really exciting drugs out there, and we have a lot of drugs in the toolbox that people can work for individuals and can go and live their life and have great quality of life and just take a pill like Accutane, like we're mentioning before, that doesn't cause in most people a lot of side effects. But there are lots of other exciting drugs in development, other immunotherapies, cell therapies, lots of exciting things coming down that are in clinical trial and under investigation. And certainly hope that something will come along that is a bona fide cure and something that's carries much less risk than things like a donor bone marrow transplant, which would really be the only potentially cure now.
Thank you so much. That is a question that everybody is always asking on it. So, okay, we are going to go to our next question. Is there a benefit to a once a month UVB treatment when in remission? Dr. Haverkos, we may have lost Dr. Pacheco for a short period of time. So okay. These are going to be, no, she's still here. Okay, good.
I'll toss that one to Dr. Pacheco if she's still there. Otherwise, I'll do my best impersonation. Dr. Pacheco, do you have a question?
Yeah. Is there a benefit to a once a month UVB treatment when in remission?
Ooh, that's a great question. I think there's kind of two school of thoughts with tapering phototherapy. And some individuals, I'll say cutaneous T-cell lymphoma experts, believe in treating someone to remission, so meaning they have no skin lesions, and then stopping the therapy. Others believe in a slow taper with the goal of decreasing therapy to one treatment every 3 months. I will tell you, I fit into the camp where I treat people to remission, meaning I start twice a week. We go to once a week, we go to once every 2 weeks, then once a month. And I have many individuals that are on treatments once every 2 months and many that are on once every 3 months. I think there's benefit.
Okay, thank you. Our next question, I'm not sure if it's a typo, if they're talking about follicular, but what is the outlook for early stage FMF? Where can I find good research on this?
I don't know, Brad. What do you think?
Sorry, show the question one more time.
Mike, can you put it back up on the screen?
Oh, what is the outlook? Okay, sure. So for the FMF, I will abbreviate folliculotropic mycosis fungoides a lot with that abbreviation. So I assume that's what they're referencing. So folliculotropic mycosis fungoides is can be a challenging subtype of mycosis fungoides to treat. There are some individuals, just like probably in other mycosis fungoides, that have a more challenging time to get into remission, more often require systemic therapies and just may have a more difficult disease to treat. And historically, there have been more folliculotropic mycosis fungoides patients that have a more difficult disease to treat. And so some people think that it carries a worse prognosis. With that said, we have lots of folliculotropic mycosis fungoides individuals who do very well and have early stage disease and respond well to therapies. So, at the end of the day, it really is very individualized to the patient and very much, it's hard to generalize too much about these other studies because, on the patient level side, all that really matters is what happens to that individual person. And so if you have favorable or, folliculotropic mycosis fungoides that does well and responds well to therapy, there's no reason to think that it's going to become this terrible disease and be difficult to treat. So I think that there's lots of reason to be optimistic and still hopeful that you're going to respond well to therapies, even with folliculotropic mycosis fungoides. With that said, I will say that we sometimes, because of the historical data that suggests that maybe that these patients sometimes can be more difficult to treat, sometimes we keep a little bit closer eye on them, at least initially, to make sure that they get into remission. We may be even a little bit more, depending on how much skin is involved in diagnosis and how that looks, we may be even a little bit more aggressive in trying starting them on both skin-directed and a systemic therapy until they get into remission, and then back off, or talk about backing off on either the systemic drug or the light. So I think that's a challenging thing about trying to generalize too much about these prior studies. And the important thing also to remember is that these are old studies, and we don't know that necessarily those will hold true in the future with all of the new exciting therapies that we have. They may be irrelevant what subtype you have. We may find therapies that work much better for certain subtypes. For example, Sézary syndrome. We now have mogamulizumab, which is can be a great drug for individuals, and in people that respond well to this drug and do well, it really has changed the outlook for many individuals with what historically was a bad, very difficult disease, and sometimes can be still difficult to treat. But just give that example, maybe some ray of hope.
Well, we know there's always people working on new treatments and always looking for a cure. So we just need to keep hoping for something good in the future. All right, Accutane is the drug of question today. So asking for a little more information, and how long does it take to see results from Accutane, and can it cause brain fog, fuzziness, balance issues?
I'll let Brad answer the first question, and then I'll answer the second.
So I'll just kind of lump in Accutane with other retinoids, because we generally use tartretin or bexarotene more so than we use Accutane, but it falls in the retinoid category, which is just a vitamin A derivative. So we usually like to wait a number of months before we really assess how well a drug is working. And that's actually true for almost any of our therapies, that we don't want to give up on systemic therapy or even probably a skin-directed therapy until we've really been on it for a number of months. It's too soon to determine if a drug is gonna how helpful a drug can be, or skin-directed therapy can be, without giving it the good good number of months on therapy. And we usually wait on average around 3 months before we'll reassess someone on targretin. And then at that point, if their response is not adequate, we may need to increase the dose of targretin, for example, or make some other adjustments or add something else. But 3 months, we generally like to wait a number of months before giving up on any therapy.
And then I'll answer the second question about brain fog, and I think there were other side effects that the person was experiencing. So again, Accutane is isotretinoin, and we use it mostly for nodular cystic acne, but also other skin diseases. It can cause headaches and blurry vision and double vision. So those are kind of the, I'll say, side effects from here above. And then it also can unmask depression. So if you're prone to depression or you're being treated for it, you can feel down and not wanting to go on with your daily activity. And that can go away if you stop the Accutane. Brain fog is not something that we commonly ask about, nor do patients report, again, my teenagers and young 20-year-olds that are on isotretinoin. Brad and I use that infrequently in cutaneous T-cell lymphoma because we often use the other oral retinoid, bexarotene. And then there's a third one, which is called acitretin, also known as Soriatane, FDA approved for psoriasis, but also a cousin to Accutane and bexarotene.
All right, thank you both for the information on it. We're going to have a couple of back-to-back questions on phototherapy. So our first one is, combining phototherapy and regular sun exposure recommended?
Oh, that's a great question. I will tell you, before we were able to get home phototherapy units, and patients did not have access to a hospital-based or clinic-based phototherapy unit, we would often counsel on, getting natural sun exposure during peak hours. So peak hours are between 10 and 3 p.m. and anywhere from 10 to 20 minutes of full body exposure. So the entire legs or the entire back or the entire front side of natural sun exposure is thought to be therapeutic for patients with certain skin diseases, not just cutaneous T-cell lymphoma. And then of our patients that are on phototherapy, I do think just in general, dermatologists counsel against sun protection, and we view phototherapy as the treatment modality. Phototherapy is often a specific wavelength of light, like narrowband UVB is 311 nanometers. And we prefer that. And then we prefer protecting the normal skin from regular sun exposure, which is the entire spectrum of UVB and UVA and potentially some UVC. I hope that makes sense.
And your statement about not having home therapy boxes early on goes perfectly to the next question. And they're asking if you can recommend a home light box, and any comment on the light box that can fold and be taken with you if needed.
Yeah, so as far as a light box that can fold, there's two companies that we use, National Biologic and Davalin. They both have an application process to order home phototherapy devices, different sizes, some are panels as big as a door, some are trifold, open out. Some are smaller units. Some are even handheld units that people can take on an airplane. So, I think it just depends on what is available by the particular company that your doctor orders it from, and then communicating with your doctor or nursing staff on what makes sense for you to use at home. But yes, they're available.
All right, perfect. So this next one, I think we might have something for Dr. Haverkos. After surgery to move a papule, gave an updated diagnosis of B-cell marginal zone lymphoma. What should be the next treatment? But before Dr. Haverkos answers, so I just want to do a reminder that they're giving Dr. Haverkos and Dr. Pacheco, they are not directly treating you. This is not a second opinion that they're giving you. They can share information based on their knowledge and what they have done with their patients.
Yeah, thanks for clarifying on them. Primary cutaneous marginal zone lymphomas. This is we've been primarily talking about cutaneous T-cell lymphoma, but there are cutaneous B-cell lymphomas, and very different diseases present very differently. The most common primary cutaneous B-cell lymphomas are either primary cutaneous follicle center lymphoma or primary cutaneous marginal zone lymphoma. And similar to maybe cutaneous T-cell lymphoma, we treat individuals with primary cutaneous B-cell or primary cutaneous marginal zone lymphoma according to their stage. And for individuals that present with a single isolated nodule or papule, usually presents as a raised, round, sort of purplish looking lesion, we often recommend just radiation to that site, and hopefully patients don't recur. That's sort of our classic typical strategy. There are individuals that present with more than one nodule, and sometimes we again will approach those individuals with radiation, and this is low dose radiation that's not penetrating deep into the skin, very minimal side effects. Or sometimes other times we can treat with intralesional therapies if that's based on the discussion that we have with the individual. There's also systemic therapies that we sometimes use, like intravenous rituximab, which is a monoclonal antibody that targets the B-cell lymphoma, or targets CD20 on the B-cell lymphoma. And we usually reserve systemic therapies for individuals who have recurrent disease or multiple lesions that extends on more than just one area of the body. So for example, if you have lesions on sort of your trunk and your arm, or both arms, or legs and arms, that would be someone that we would think about systemic therapy. If it's just isolated lesion and it's within a single, something that can be radiated easily, we often just defer and refer for radiation therapy because it's minimal risk and minimal toxicity. But it's also individualized, by the patient. When individuals have a single lesion, if it were to recur, and if it were to recur multiple times, there may come a point where we would want to think about systemic therapy as a way to keep it away. So it's also weighing other factors that may be important to the individual. And there's fortunately a number of different ways we could treat them. Important to mention that in primary cutaneous B-cell lymphoma, we always want to separate this from systemic B-cell lymphoma, where you have lymphadenopathy or other organ involvement. And so we always make sure that it is just isolated to the skin. But in general, very favorable outcomes, very favorable prognosis. We like to say that people will live a long life and die of something else from other than lymphoma, which I think is a good thing.
Thank you so much, and thank you for the positive note at the end. So we have our COVID question, and can someone with CTCL safely travel during the pandemic? Is it too dangerous, even if wearing the N95? And then I think what might be easier to address is how does COVID affect cutaneous lymphoma patients?
Yeah, I guess I can start. And everything kind of depends, and I think it's a good time to remember that kind of what Autumn was saying before is that everybody's has their own set of circumstances that may make COVID risks higher or lower. Some people are young, some people are old, some people are on systemic therapies and not, and these things all weigh into what the real risk of infections in COVID might be. So I think, but in general, infection is a concern in cutaneous T-cell lymphoma, including COVID. And it really, the risk of infection in COVID really hinges on, where you're at in your disease and what therapies you've been on recently. But for most cutaneous T-cell lymphoma patients, most are early stage, most are not on systemic therapies, and most are not on immune suppressive systemic therapies. The risk is not generally different than what it is for the general population of someone of your age and other medical problems that you might have. So that's, we have seen, to maybe the second part of that question, and also kind of tied into vaccines a little bit, because it's usually a question people ask as a follow-up. We have seen people that have had COVID or even had the vaccination that have had a little bit of flare in their skin, or their skin's gotten a bit worse. But then that, with the continuation of the treatment that they're on, it gets better. So it's certainly a bit scary, when that happens, but we've seen that, and I've talked to other individuals that have also seen that as well. We don't think that COVID or the vaccine puts people at any kind of increased risk for the disease to progress, or for you not to respond to a therapy, or for the disease to become out of control. So it's not any kind of risk factor that is negative towards the disease. It's just at least not been shown to be that as of what we know so far. So I think those are maybe some important things to keep in mind about COVID and really infections in general. And we see that, I mentioned that the vaccine, that sometimes we see a little bit of people, the skin flaring a little bit. We can also see that happen with other anything that revs up the immune system, other infections, other immune other systemic therapies that are immune activating sometimes can cause the rashes to get worse before they get better. That's just a product of your immune system getting kind of overexcited, but it's not in general a reason to be concerned or to be alarmed.
All right, that was some really great info. So we have a little bit less than 10 minutes, so we're going to try and get through a few more questions before we run out of time. So our next one, I'm stage 1B and doing phototherapy, interferon, and soon to begin photopheresis. What are your thoughts on vitamin supplements?
So I'll start. I'm not a huge fan of supplementation. When I do get asked that in clinic, and patients have, specific questions about specific supplements, we're at an academic institution and we will often refer to an integrative practice where pharmacists and doctors are trained in really dissecting supplements and whether they're beneficial for patients with this particular diagnosis. So we have the luxury of that. So I defer that question to those experts, which are not on this call today. I will make one comment on a supplement that probably makes sense, and that's oral vitamin D3. We do in our intake draw lots of labs, and one is a vitamin D level. I think in the field of dermatology, because we tell people to sun protect, a lot of people have low vitamin D levels. And so we take note of a very low vitamin D level in our clinic, and we'll often ask those patients or get guidance from a pharmacist on our clinical team to supplement with vitamin D. So if there were a supplement to take, it would be a vitamin D3 available at most pharmacies at probably 2,000 international units a day. But I want to hear Brad's thoughts on this.
Yeah, no, I echo your sentiments. Two things. One thing about supplements and vitamins is we just want to be sure we want to be sure they're not interacting or causing a problem with what other therapies you might be on. And the problem with a lot of the supplements is they're just not studied well. A multivitamin's not going to hurt anyone, but we worry about some of the other supplements that may be able to interact with different therapies that we're giving. So in general, I tend to have people avoid them. Of course, people like take supplements and vitamins, and that's when we refer to other folks that might have more expertise. I will say that the vitamin D, I agree. Vitamin D it's been shown to be a helpful vitamin. It may have, it's been studied in a lot of different lymphoma studies and may have some helpful properties that help the immune system. It's important, though, to know or to remember that the only thing that's really been shown and helpful is supplementing vitamin D to a normal level. We don't want, we see sometimes people come in with very high levels of vitamin D, and that doesn't make any sense to overdo it and take, 10 times what the daily amount is. And that's true for any vitamin. And so I don't, multivitamins fine, 1,000 units of vitamin D or 2,000 units is fine in most individuals, but you just have to be careful and not overdo it, because I think you can cause some real harm if you take more than what is recommended by your doctor.
That is some good bit of info to make sure you're not trying too hard with some of those over the counter. All right, so this is going to be our last question tonight. Is it normal for lesions or skin irritations to be on multiple areas of the body, same repeated areas, and to appear in hours and dissipate over days or weeks?
So I'll jump in with that. I think that's uncommon with this disease. It's rare to see lesions come and go. In fact, the hallmark of the disease is just the opposite. People have eczematous patches and plaques on the skin that look like eczema that persist for years and do not go away. So for lesions to come and go would be very rare.
Mm-hmm.
Okay, thank you so much. So that is the last of our questions. And I want to ask Dr. Haverkos, Dr. Pacheco, do you have any additional parting thoughts before we go?
No, I just want to thank the Cutaneous Lymphoma Foundation for offering us to be able to communicate to patients, out there that you are connected with. It means a lot to us.
I'm so glad to hear that. Thank you. All right, well, I want to thank everyone. Oh, sorry, Dr. Haverkos.
Yeah, I second that. Appreciate you too, Autumn. Thank you for your help.
All right, thank you. So thank you both of us for taking time out of your busy schedule. I know that there's a lot of patients out there to see and a lot of charts that need to be completed. So thank you everyone else for attending today's webinar. We look forward to seeing you at future programs. And please, again, do not forget to take your survey at the end of this webinar. It is very helpful for us to provide relevant content for you. Have a wonderful evening, everyone.
Bye, everyone.